share, please.
Yeah, is it visible, Jay?
Not
Not
yet.
yet, George.
So Anand, by the time George gets in, how was the other eye in your case?
Yeah, the other eye was stable. It didn't show any increase in fluid or any form. It was kind of stable right through. Vision also didn't change, which was surprising and fortunate too.
Is it visible, Jay?
Yes, yes. Now we are good. Please.
Can I
Yeah,
start
please
presenting?
start. Yes, please.
Yeah, good evening all. Would like to look at this anterior choroidal loculation of fluid in central serous chorioretinopathy. So this is the first of the three eyes which we have seen with this finding. So to time constraint, we'll be discussing only the first case. And first case, 60-year-old male who is a diabetic, hypertensive and coronary artery disease patient who has a best corrected vision of 660 in the right eye and 6/9 in the left eye, and he has immature cataracts in both the eyes. So the right eye shows chronic central serous features with subretinal fluid, intraretinal fluids, thick choroid, and serous pigment epithelial detachment in his both the eyes. Here also you can see the thick choroid, subretinal fluid, and serous detachments. The fluorescein angiography at presentation was having diffuse RP epitheliopathy at the macula with few mild NPDR changes and diffuse leakage in the late phase. Both the eyes had the RP tracks and diffuse leakage at the macula in both the eyes. And with this, we made the diagnosis of chronic central serous with mild NPDR, and he underwent cataract surgery in both the eyes. And vision was 6/9, best corrected in both the eyes. 6 months later, he comes with a sudden defective vision in only in the right eye, and vision had dropped to 1/60, and he comes with a bullous fibrinous exudative CSR with inferior bullous RD, and he had this very exudation, thick exudation at the macula at that time, and he has peripheral choroidal detachment also. So this is the left eye remains the same. The serous PED and subretinal fluid and chronic CSC picture remains the same in the left eye. And this is a fluorescein angiography showing the blockage due to the thick fibrin at the fovea and the diffuse RP leakage at the macula with mild NPDR changes. This is a wide field picture showing the peripheral 360-degree choroidal detachments. And this is the montage showing the 360-degree peripheral detachment inferior exudative RD. And also the ultrasound showing the inferior serous CDs with inferior exudative RD. So the left eye remains the same, mild NPDR and diffuse RP epitheliopathy leakage in the late phase. Chronic CSC picture remains the same. So we did a low fluence PDT multi-spot technique and treating the entire area of diffuse RP leaks. And you can see here the subretinal fluid started reducing by 1 month, and the fibrin started organizing under the macula, and the CD height of the peripheral CD started reducing, and vision 1/60 to 5/60 now. And this is left eye also reduced fluid. And this is the right eye showing at 2 months, showing that the subretinal gliotic band is forming and the peripheral CDs have resolved now. You can see that only the inferior fluid pocket in the inferior periphery. There is no CDs at this point. This is 2 months post PDT. This is a picture 4 months post PDT in the right eye. Both eyes, there is this RP degeneration at the macula. The right eye, the subretinal gliotic band has formed because of the organized fibrin, and vision has improved to 6/18 in the right eye. This is the resolved fluid, and you can see the subretinal gliotic band that has formed in the dry macula in the right eye. The left eye, you can see there is still remaining subtle subretinal minimal fluid in the left eye post PDT. So here we consider the first diagnosis at presentation was idiopathic uveal effusion syndrome, but the bilateral multimodal imaging features of chronic CSC and on all the imaging modalities, as well as the absence of leopard spot fundus or fluorescein angiographic features, guided us to this diagnosis with chronic CSC. And as you know, the pathophysiology of CSC is unclear, but we all know that there is choroidal hyperpermeability. Whether this is secondary to the venous stasis, which has been discussed by Dr. Rishi and Dr. Anand also, or it is an inner choroidal ischemia as suggested by OCT angiographic studies, we don't know. But the recent ultra wide field ICG angiographic studies have shown that when there is a temporal, for example, in this case, temporal choroidal hyperpermeability, the dilated vessels track back to the congested vortex vein ampullae only in the corresponding segment. For example, here it is temporal, so both supratemporal, infratemporal vortex vein ampullae, probably suggesting that it's an outflow congestion in this kind of a chronic CSC setting. I won't say this has been touched upon by Dr. Rishi and Anand. This intervortex anastomosis that we see across the macula as pachyvessel also gives us some clue that there is vortex vein congestion in these eyes. So lastly, there is an entity on swept source OCT called posterior choroidal loculation of fluid by Spade and Ryan, which showed that when there is excess choroidal thickening beyond 400 to 500 microns of choroidal thickening, the fluid gets accumulated in the outer choroid like this, interdigitating between the pachyvessels or the outer choroidal vessels. So when choroidal stroma gets saturated, fluid either comes under the RP as pigment epithelial detachment or like this posterior choroidal loculation, or Spade was suggesting rarely it could accumulate in the suprachoroidal space pre-equatorial, where the choroid is loosely attached to the sclera. So why atypical CSC here? Because the patient was already on follow-up for chronic CSC, and he had bilateral serous pigment epithelial detachment, diffuse RP epitheliopathy, and he had developed a fibrinous CSR, bullous CSR, and response to PDT was quite remarkable in this case. So I would conclude we have reported it's coming out next month. So atypical bullous CSC with anterior choroidal loculation of fluid and posterior choroidal loculation we have already seen and is well described. PDT seems to be a promising treatment in this rare variant of CSR, and multimodal imaging is the key point in diagnosis and differentiating from the other differentials. So thank you.
Excellent, excellent case. I had a quick question because I'm sure a lot of people in the audience must be wondering that did you have an axial length for your patients? Did you work
this patient had a normal axial length. I hadn't mentioned here, but then he had a normal axial length in both the eyes.
Okay, so are we saying this is a CSR with UES or an effusion in both the cases, or it is just a progressive CSR which led to this, or they all fall into a venous insufficiency or venous congestion theory?
Yeah, Jay, I just want to make a comment. Now, slowly it is coming to that in CSC, though we say the inner choroidal ischemia, that could be secondary to the choroidal congestion, and more evidence that vortex veins are also, as I showed in the ICG angiographic studies, showing that the vortex vein is congested. We all know that not only in CSC, but in uveal effusion syndrome also, we know that abnormal scleral thickening is there, and that is causing a vortex vein congestion. Probably in CSC, we don't have a vortex vein abnormal scleral thickening in all the cases, but then there is some overlap between these two conditions because there is no typical CSC leak on fluorescein angiography in Anand's case. But my case, we had 3 eyes with this presentation, which is with bilateral CSC features. While the patient was on follow-up, they developed this bullous kind of detachment and fibrinous bullous detachment, and they developed CD. So I think there is an overlap wherein one case the scleral thickening probably is amounting to the vortex vein compression. Here we don't know what is the real pathology in CSC.
So George, yeah, I'd just like to comment a couple of things. So one is in George, when you look at George's case, as well as if you look at the Ames case, which I highlighted, Pradeep Venkatesh's case there, both were CSCRs with inferior detachments, and they treated it with a scleral resection, whereas George treated it with a PDT. End result, both resolved. So it is very unique that in both cases, one treated it by treating it as a uveal effusion, The other one treated it as a CSCR. And the end result was that there was a resolution of both. Both had, significant detachment. Both had fibrinous content with PDs. My case did not have the PD, the classic PD. Perhaps if it had waited for some time, if we had waited for some time, maybe the PD might have come out. Maybe we would have had a more classic blowout of the RP, and then it might have shown up more typically. So what I believe is that, all this is in a continuum. We now, as we are doing more wide field ICGA, that is where we are able to recognize. Now, even in my case, I don't have a wide field ICGA, and I couldn't really montage it, but I'm quite sure that, if we had wide field ICGA, we would recognize and reconcile most of these cases to somewhere in that time point continuum of pachychoroid up to UES. So I think that is there. Then the other point about scleral thickness. Now, as you understand, even you, that's why I think Yoyama's papers are brilliant, because 20 years ago, even with just 1 or 2 cases of type 3, he was able to put forward that theory that with those cases, sclerectomy may not help. And that is where it was good to have the Shields paper coming in with 104 eyes, where they show that there's something else happening and steroids help. My experience with steroids in classic nanophthalmic eyes is it actually doesn't work. It actually, I have found it actually kinds of worsens. I've actually given cases steroids and I've seen UV diffusion in 17 millimeter, 18 millimeter eyes actually worsening. And I always thought that the water retention caused by steroids is what's happening here. So there are probably slightly different pathomechanisms happening between 1 and 2 and the type 3 UVL fusion syndrome, where sclera doesn't make a difference.
Great.
So this is a
Judy, you
really
were saying
nice series of cases between Rishi's case, Anand's case, and George's case. As you're saying, it may be a spectrum that we are seeing with commonality of vortex vein congestion with or without scleral thickening based on axial length and other things. And sounds like the treatment of choice is to decongest, whether it's with PDT. Studies have shown that after PDT, CSR cases, the choroid does thin compared to pre-treatment. So again, showing that there must have been some decongestion. Steroid may be also decongesting, as an anti-inflammatory, and then the surgical way is also decongesting, and maybe the wide field ICG may help us to be better selective about the quadrant that we may want to do surgery, possibly. And this is it's a little bit left field, but the right eye that had vision loss because of the fibrinoid deposit right at the macula, maybe we could have injected a gas ball, a small gas bubble or something, had the patient positioned so that it doesn't accumulate at the fovea, at the macula, but somewhere displaced it somewhere else. But I think these are really all very interesting.
But giving steroid, because giving steroid in my kind of a case, I would never do, because it's like a chronic CSR and is worsened, and I don't want the other eye to develop a bulla CSR because of my steroid. So I would be really scared to give a steroid. But one of the 3 eyes, I've just presented one eye. One of the 3 eyes, I did a sclerectomy, but it never worked. Probably because no scleral thickening was involved. I don't know, but it never worked. And finally had to do a drainage, endo drainage, settle the retina and do a PDT, and it worked actually.
Yeah, so I just like to comment on Judy's and George's comment, and also reconcile this with Rishi's case. Now, if you see in my case, I had done a PDT to just those hyperpermeable areas. And what you also notice, which I slightly alluded to in a presentation, is that SRF in the macula went, but also with that, the peripapillary component, the skytic fluid near the disc, that also went. So this also seems to say, and the same thing in Rishi's case also, he did a PDT, but fluid all around went. So if you can just decongest or silence with pharmacotherapy, that hyperpermeable area, that seems to have some sort of an effect all around and decongest the entire system somehow. So even though we are applying the laser to just this particular area, there may be some mild irradiation happening around, and we don't know if that is helping in the entire system getting silent.
Anand, Rishi, and Jay, I just want to bring in here. I know I have been doing a yellow micropulse laser for this early cases of CSR, and I've been having fairly good results with the PDT not being available in our country. So in these cases, if you repeat a yellow laser after about 3 months and sometimes even on a monthly basis, it's working very well. So we really do not know, as I think Lalit asked, what is vertopolfin doing? If you can have a yellow laser working similarly, I think PDT can work without a vertopolfin.
Yeah, I agree. A quick comment to that. I mean, I was holding myself back because of time constraints in the Rishi's case. He raised a question about yellow laser, and I think Jay also has experience. We have had very good results with micropulse subthreshold yellow IQ 577 for CSR. We have not had the same kind of experience with diabetic macular edema, which many people in the West and I think Eduardo Mineta's group and all have had. So I think CSR, given the fact that we don't have PDT, right now, chronic CSRs around the 3 months to 6 month time, I think it does well with yellow micropulse laser.
I think, Anand, the basic problem is calculating the sub-threshold dosage, and that's where the problem happens. You know, your fiber optic cable gets old, and you really do not know what the sub-threshold is, and that is
Exactly.
where I think
Yeah,
the
because
issue
it's an
comes in.
invisible burn. How do you
Yeah.
paint the entire macula as in my case? When you are not sure about, sometimes you don't know what is the threshold. So when that is the only issue, like bilateral diffuse macular leakage actually.
That is the reason, Jay. I thought that even TTT may work. I could
Yes, sir.
do. You see, even TTT, because it's a longer wavelength we are talking, so that it's hitting at the choroid.
George and myself have done a lot of TGT, and we were waiting to get into that. But
No. Now that vertiporfin is not available in India, so I
absolutely,
thought
Yes,
of
sir.
doing.
We have quite an experience. We have published also. Jay knows that. Like
Yeah,
almost we have compared with PDT and results were almost comparable in.
that's what. Yeah,
Yeah, I think
let's
micropulse does work, and 577 at least in my hands has been working extremely well. And people may deny it, but we've been getting excellent results in
So the
micropulse.
reason of my
let's
asking the question to Rishi was the same. What is vertiporfin doing in this?
let's go back